Welcome back, everybody. This is Jason Williams, and I'm excited to have you back for our hospital medicine point-of-care ultrasound course. This is lung ultrasound part 2. Hopefully you've started with lung ultrasound part 1, where you had the basics of A lines and B lines and how to acquire those images. If you haven't, you can go to my website at proceduralist.org to review the previous content. So as an overview of the course, it's a 4-part series. We'll be looking at volume status and CHF management today in part 2. In part 1, we've talked about getting good images and bringing out A and B lines and what they mean. In part 3, we'll talk about several other useful ultrasound skills like pneumonia, atelectasis, pleural effusion, and pneumothorax. And then part 4, we'll put it all together with several of those cases. Today in particular, we're going to apply our A line and B line knowledge from part 1 specifically to pulmonary edema. We'll work on quantifying the severity of that edema and applying that to volume status cases. It's important to remember when we talk about volume status, there's several compartments to think about. One of them being pulmonary edema, which we'll talk a lot about today, but also leg edema and other peripheral compartments like ascites and pleural effusions. Central venous pressure is another important volume compartment, as well as effective arterial volume. We're going to apply all these concepts to several cases, particularly with CHF management today. So let's dive right in. Case number 1 is a 61-year-old male who's an active 50-pack-year smoker. He has heart failure with mid-range ejection fraction of 40% and an active cocaine smoker as well. His chief complaint to the nurse in the triage area is the fluid is back, and he's been admitted several times for CHF exacerbations in the past. He reports 2 weeks of shortness of breath and leg swelling, as well as orthopnea with a productive cough. His exam is notable that his lungs are clear of auscultation, and there's only 1+ leg edema. His chest x-ray was read by a radiologist saying it's most consistent with a CHF exacerbation resulting in mild to moderate pulmonary edema. Interestingly, his BNP was as low as it had ever been at 95, and it's previously been as high as 1800. The plan from the overnight resident was to initiate IV diuresis for a CHF exacerbation, but there's some conflicting information here. The lungs were clear to auscultation, and there wasn't much leg edema, but the chest x-ray was concerning for CHF. And the patient tells you the fluid is back, I'm feeling short of breath. And he does have orthopnea, but his BNP is normal. So it's hard to weigh out all these data points in terms of is it CHF exacerbation or is something else driving his shortness of breath? This is where lung ultrasound can really add an additional data point to help sort this out. So we did a 6-point lung exam where we looked at the anterior, lateral, and posterior lung zones, both on the right side as well as the left side. This exam has moderate sensitivity. If you really want to go looking for smaller infiltrates, you should do more than 6 exams. Some people will say 8, 28, I've even seen a 96 zone protocol. But 6 exam zones will give you moderate sensitivity for detecting things like pulmonary edema. And don't forget these lower lobes, which is where pulmonary edema tends to start in a gravity-dependent fashion back here, where you get crackles at the bases. This is where you'll find B lines most commonly with CHF. But in this patient, we see an A-line pattern, A-line, 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 and A-lines on the left side as well. This A-line pattern, you'll remember, is consistent with air. There is no fluid in this patient's lung. Furthermore, we did an inferior vena cava ultrasound, and it confirmed his central venous pressure is actually quite low at 3 millimeters of mercury. So what's happening in this case? How do we diagnose CHF in the emergency department accurately? This patient complained of orthopnea, but the specificity of his orthopnea is terrible. In fact, almost 80% of the time, if a patient like this says they have orthopnea, they do not have pulmonary edema or high pulmonary capillary wedge pressure. Same thing, this patient had a normal BNP, which is decent sensitivity at 85%, but still 15% of the time you could have CHF with a normal BNP. How about the specificity of this patient's chest x-ray? It was read as CHF, but there's no edema. Well, the radiologist, unfortunately, is wrong about 20% of the time, that they may overread and call it CHF when in fact there is no lung infiltrate. But when you compare lung ultrasound to your x-rays, labs, and physical exam, you can see lung ultrasound blows all these other modalities out of the water. And in fact, point-of-care ultrasound admission improves diagnostic accuracy for residents just like this when it comes to shortness of breath. This has been proven in several studies. So when we go back to this patient, the plan is not to do IV diuresis. What is causing his shortness of breath? What should our plan be? Well, he's a 50-pack year smoker who's actively smoking both cigarettes and cocaine, and he's never had pulmonary function tests. We suspected that this was a case of bronchitis and COPD exacerbation and treated him as such, and his shortness of breath and cough resolved. Furthermore, we sent him home on long-acting antimuscarinic tiotropium, got him his outpatient PFTs, and most importantly, enrolled him in smoking cessation and cocaine cessation program, and he hasn't been admitted in the last 9 months after remaining sober and off cigarettes during this time. So this is a case, even though the patient's been admitted for CHF before, and it seemed like a slam dunk, he felt like his fluid was back, this must be another CHF admission. This time around, he's given a new diagnosis of obstructive airway disease, and really needed a different change in management this time. Let's take a look at another case. This is a 71-year-old male with COPD, heart failure with reduced ejection fraction of 20%, and atrial fibrillation. And his chief complaint to the nurse in triage saying, "I have COPD," saying this feels like my usual COPD exacerbation. And he reports worsening gradual shortness of breath, wheezing, and insomnia. He wakes up in the middle of the night short of breath. He denies cough. His exam is certainly positive for wheezing, but there's no leg edema. And his labs are notable for a rising creatinine. He has an acute kidney injury, and his creatinine's jumped from 1.5 to 2.5. And his BNP is slightly elevated from the last time it was checked, rising from 1,000 to 1,800. The chest x-ray was read as hazy reticular opacities, less prominent than the last study. So maybe the chest x-ray is better than last time. It's hard to know exactly what the radiologist was getting at here. So the plan for this patient was let's treat him for COPD and hold the torsemide. The thought that this is all a COPD exacerbation, he's been over-diuresed and has a pre-renal AKI, but this is where volume status really comes into play. Could this be CHF and a cardiorenal AKI? Or is this a dry lung and a COPD exacerbation and a pre-renal acute kidney injury? What is this patient's volume status? Well, after treating for COPD and holding the torsemide, by hospital day 3, there had been no improvement in this patient's shortness of breath, and the creatinine continued to rise during this time, as well as the BNP. At this point, I was called for a volume status consult to help weigh in and see where is this patient's volume. Is this a pre-renal or cardiorenal picture? Is this shortness of breath due to COPD or CHF? So here's this patient's lung ultrasound. Quite different than the last patient. You'll remember from part 1, these vertical spotlights coming from the pleura are B-lines. B-lines are bad, and in this case are indicative of pulmonary edema. You can see them anterior and laterally on both sides, consistent with CHF, and there's no reason to look in the posterior lung zones because we already have the diagnosis. If these anterior lateral zones were negative and no signs of B-lines, it'd be reasonable to go look posteriorly because you may pick up B-lines there because that's the most sensitive zone. But I think we know what's going on here. He's got a diffuse bilateral infiltrate. And if you score these B-lines, as we learned in part 1, you can see it's pretty high. His total B-line score is 12. Just as a brief refresher, how do we score B-lines? We take a freeze frame and we count the highest number of B-lines on a single freeze frame. So in this case, you see 3 B-lines. In this case, you see closer to 4. 1, 2, 3, 4. In this case, it's hard to bring on more than 2. You can see 1 here. Maybe we can bring on a second one. So faintly, maybe 2 right there. And finally, 2 to 3 B-lines in this left lateral zone. And you add all those together to get 12. Our volume status exam is not done yet. We should go look at his inferior vena cava. And here, interestingly, the central venous pressure is 8, which is considered within normal range. So we have a diffuse bilateral lung infiltrate with a normal central venous pressure. Could this be CHF? Could it be something else? Well, let's look at first scoring this lung exam, and then we'll talk more about how to integrate the central venous pressure into this patient. So let's assume this is cardiogenic pulmonary edema. And there's been some nice studies in the scoring technique we just talked about when you look at anterior and lateral and add up these 4 zones. If you get 1 to 6 B-lines, you end up in a mild edema category, 7 to 12 B-lines, moderate edema, or this patient, he had 12 B-lines, he has severe pulmonary edema. And these correlate with outcomes, and this is where this data comes from. that if you go home with 12 or more B lines, you're 12 times more likely to come back to the hospital for CHF. If you go home with 6 B lines and you're still short of breath walking around the room, otherwise known as New York Heart Association Class 3 heart failure, you're 7 times more likely to come back to the hospital. If you're not that short of breath, but you still have 6 B lines, you're 3 times more likely to come back to the hospital. And don't forget about the peripheral edema. If you have 2+ ankle edema or more, you're 4 times more likely to come back with CHF. Remember, this patient's inferior vena cava was technically normal. If you look at inferior vena cava ultrasound, it's actually the least predictive for who's coming back to the hospital compared to these other markers of either peripheral edema or pulmonary edema. So I really find lung ultrasound and pulmonary edema drives who's coming back with a CHF readmission more than inferior vena cava ultrasound. Okay, so if we go back to this patient, there was no crackles on exam. It wasn't obvious he had pulmonary edema in the emergency department. But crackles have a very poor sensitivity for CHF. Similarly, this patient didn't have much leg edema, but leg edema is only 40% sensitive for CHF. So 60% of the time, patients will have CHF and no significant leg edema. The chest x-ray missed CHF this time, and again, the sensitivity for chest x-ray can be pretty low compared to lung ultrasound, which really dominates all of these modalities, whether it's imaging or physical exam for detecting pulmonary vascular congestion due to CHF. So let's think about this patient for a sec. When I discuss volume status, it's not fair to say this patient is wet or dry. I really think about 4 separate volume compartments, and I try to grade them individually to get a more nuanced approach to what each individual patient's volume is. So for instance, I think about peripheral edema and I measure how much pitting edema is in the legs. I think about pulmonary edema and I use lung ultrasound to grade the severity of that. I think about their central venous pressure and I measure their IVC and JVP ultrasound to assess that. And the final category is effective arterial volume, which is the hardest to measure, but we get clues about what their arterial volume is. If the blood pressure is dropping, they could have low effective arterial volume, or if their creatinine's rising, they could have low effective arterial volume causing a pre-renal AKI. So what about our patient? He really had no peripheral edema, so he was dry in his legs, but he had moderate to severe pulmonary edema. His central venous pressure, he had a moderate amount of fluid there. CVP8 is right in the middle of the zone. And it's hard to know what his effective arterial volume is at this point. Certainly his creatinine's on the rise. So when he was holding diuretics, his creatinine was rising. We initiated IV diuresis because of this moderate to severe pulmonary edema, and his creatinine had a nice drop, confirming this was a cardiorenal AKI that improved with IV diuresis. So normal central venous pressure does not rule out acute CHF. When a lot of people think of volume status in ultrasound, they only think about the inferior vena cava, but you have to think about these other compartments. Particularly lung ultrasound is really key to volume status. That's the most predictive of who's going to get readmitted, is how much fluid do they have in their lungs that causes patients to feel short of breath and they come back to us in the hospital. And this was exemplified in a nice study of end-stage renal disease patients who were on hemodialysis, and they were considered euvolemic on physical exam by the nephrologist. Then the nephrologist was trained to do lung ultrasound to guide how much volume to pull off during their dialysis session. And when they detected more pulmonary edema, they ended up pulling off more fluid, which caused a reduction in weight and decreased hypertension over time. So under these multiple domains, lung ultrasound is really a key component of volume status that's underutilized in the point-of-care ultrasound world. All right, let's go into our third and final case. This is a 58-year-old male with hypertension, hyperlipidemia, and type 2 diabetes, who also came in complaining of shortness of breath for 1 week. He endorsed the shortness of breath with exertion, as well as paroxysmal nocturnal dyspnea, so waking up in the middle of the night short of breath, and had increasing leg swelling as well. On his exam, it was notable he was febrile in the emergency department and appeared to be in some respiratory distress. There was no obvious jugular venous distension. There were crackles at the bases, and he had marked lower extremity edema that was graded as 3 to 4 plus. His labs were concerning for an acute kidney injury with a creatinine rise from 1.1 to 2.16. His troponin was rising as well from 1 to 2.5 overnight, and his BNP was elevated at 1300. The chest x-ray here was read as no gross evidence of airspace disease. When we applied lung ultrasound to this patient, we identified bilateral B lines. These images aren't perfect. You can see here there's probably too much gain, it's too bright, and the pleura is not horizontal. The probe should probably be rocked and fanned to bring on more B lines and get perpendicular. But when you freeze frame, you can see that there are some B lines here. So a total of 7 to 9 B lines. Depending on how many you count, again, if these image quality were improved, we may detect a few more. Furthermore, the central venous pressure was quite elevated on this patient at 15 millimeters of mercury. And there was newly recognized moderately reduced ejection fraction. It was not known that he had this reduced EF previously. So again, our volume status exam on this patient includes not only lung ultrasound, but central venous pressure ultrasound, as well as a cardiac ultrasound in this case. So how do we start to put this together? So in thinking about his 4 compartments of his volume status, he has marked peripheral edema. This 3 to 4 plus leg edema is a lot. Pulmonary edema wise, he's in some respiratory distress, and he's got at least moderate B lines, which may account for that. And his central venous pressure is quite elevated as well. But I'm a little bit worried about his effective arterial volume. His blood pressure is normal, but he's febrile, and his creatinine's on the rise. So I wonder about sepsis and potentially causing a pre-renal AKI in this patient, along with CHF. It'd be nice to have one diagnosis, but there may be multiple in this case. So on hospital day 1, he was given 80 milligrams of IV Lasix, and his creatinine continued to rise. So cardiology recommended stopping the Lasix on this patient. But after stopping Lasix, he woke up in the middle of the night short of breath and had return of his respiratory distress. It had initially improved with the IV diuretics, but now was getting worse again. So he was given Lasix 100 milligrams IV overnight to try to address the acute respiratory distress that seemed to be getting worse. And fortunately, the next morning, his creatinine continued to creep up from 2.6 to 3.1. And this is where thinking about volume status in these different compartments can help us sort through this complex case. He's got an infiltrate in his lungs, but his creatinine's rising. He's in respiratory distress and with marked leg edema, which points towards CHF, but is this Lasix causing reduced effective arterial volume and killing his kidneys? When we think about these different compartments, we can start to think about which one we want to prioritize and investigate. Because he could be dry or low effective arterial volume, but still have very high central venous pressure, leg edema, and pulmonary edema. And that low effective arterial volume could be driving his rising creatinine, while the other compartments remain quite overloaded. And we're going to have to prioritize one of these compartments, either his effective arterial volume and support his kidneys and blood pressure, or try to diurese through some of these volume overloaded compartments. So let's talk a little bit more about worsening renal function during CHF diuresis. It's been well studied over the last 5 years or so, and our knowledge has really grown over time. For instance, the DOSE trial, which looked at acute CHF hospitalizations, it randomized patients to different diuretic dosing was the initial trial, and then they did this really nice follow-up of patients that had a creatinine rise over their 72 hours of IV diuresis. What they found is, in all the patients in the DOSE trial, 18% had worsening renal function during the trial period, which they defined as a creatinine rise of 0.5 or more. The 95% confidence interval included a creatinine rise of about 0.9 or so. And it's essentially, if you follow those patients who are diuresed during their hospitalization and had worsening renal function, and you follow them over time in terms of their death, rehospitalization, or ER visits, patients with stable renal function in the blue line and worsening renal function in the green line have no difference in outcomes. So whether your creatinine worsened with diuresis or your creatinine was stable, you behave the same at 60 days. Interestingly, the group that did the worst are those with improved renal function, like our last patient who had a cardiorenal AKI and his creatinine improved with diuresis. They are more likely to have death, rehospitalizations, or ER visits, and likely because they're the sickest patients. If you have cardiorenal AKI, even though the creatinine's improving and we pat ourselves on the back and the numbers look good, you're just at higher risk for death, hospitalization, or ER visits because you're sicker compared to these other groups. So the DOSE trial taught us that we really shouldn't be too worried about a creatinine rise of 0.9 or less during the hospitalization. It's not going to worsen outcomes at 60 days. Another large trial, the ESCAPE trial, looked at a similar conclusion. This was a much sicker population overall. So this is patients that severely reduced ejection fraction at 30% or less, requiring pulmonary artery catheterization. And in this group, a lot more patients had worsening renal function, almost 40%. And what they did, they actually looked at who had temporary worsening renal function and who had persistent worsening renal function. So some patient, their creatinine improved at 60 days and returned to baseline. Others, the creatinine really didn't improve at 60 days. Interestingly, there's no difference in outcomes. That even if their creatinine is still high at 60 days after their CHF readmission, there's no difference in terms of death or rehospitalizations. The great thing about this trial is they also documented who went home with clinical congestion. So at the day of discharge, did they have elevated jugular venous pressure, crackles on exam, S3, lower extremity edema, or orthopnea? And on the day of discharge, did they go home with a normal central venous pressure and a normal pulmonary capillary wedge pressure? And we look at death at 180 days, the patients that did worse were the patients with worsening renal function and congestion who were sent home. So if your creatinine was rising and you were wet, you were much more likely to die, whether it was clinical or through the pulmonary artery catheter measurements. And same thing, those patients that were rehospitalized at 180 days were the patients who had worsening renal function and congestion, aka they still had crackles or peripheral edema, or patients with stable renal function and congestion. The group that ended up doing the best were those that had worsening renal function and no congestion. So they were sent home and their creatinine was worse, but they were dry. They had no more peripheral edema, no crackles, and they had normal hemodynamics. So in other words, congestion at discharge is more important than worsening renal function. If your patient's wet, aka they have elevated JVP or crackles or edema, keep diuresing. If they have high central venous pressure, keep diuresing, and don't worry about the worsening renal function. As long as you send them home and they're dry, they'll do much better. So here's my conceptual framework of how I decide when to stop IV diuresis in my patient. So I always think about what is their effective arterial volume first and foremost. I want to make sure that their brain and their heart is well perfused. And so if patients are getting hypotensive on IV diuresis or there's a creatinine rise greater than 1, again, from the trials of the dose trial, that creatinine rise of 0.9 or less was very common. If the creatinine rise is over 1, you have to stop and ask yourself, is something more than just the IV diuresis causing this creatinine rise? If it is, you need to stop and reassess that patient. So in our patient, his creatinine rise was over 1. So we need to stop and figure out what's going on here. That's a little bit out of proportion from the dose trial. We need to make sure we address his renal function and make sure we're not worsening his effective arterial volume with IV diuresis. So what are type of things that can worsen effective arterial volume? So decreased blood pressure is a function of your cardiac output and your systemic vascular resistance. So if you're in cardiogenic shock, you could have a worsening creatinine, and maybe you need inotropes to continue IV diuresis. I also think about the rate of diuresis, that if you drop their intravascular volume too fast, for instance, if the patient pees 7 liters in a single day, they may not be able to reaccumulate and replace that fluid in their intravascular space. And as a result, they could get hypotensive due to worsening stroke volume and worsening cardiac output because the rate of diuresis is too high. Maybe we need to give them less diuretics so they pee less liters per day to prevent worsening effective arterial volume. Or maybe their systemic vascular resistance is too low. Are they vasodilated because they're on too many afterload reducing medicines or too many hypertensive medications? Or are they vasodilated because they're septic? In this case, the patient was febrile and there's a concern that he had sepsis causing peripheral vasodilation, which in addition to the diuresis is really going to worsen his effective arterial volume, decrease blood perfusion to his kidneys, and really cause that creatinine to rise. Other things that can cause creatinine rises of over 1 outside of just blood pressure and effective arterial volume issues are intrinsic renal disease. So always make sure we're not missing a glomerulonephritis or nephrotic syndrome, and always make sure we're not missing hydronephrosis or bladder obstruction as well. So when I have patients who are getting hypotensive or creatinine rise over 1, I stop and I ask myself, do they have any of these issues going on? And I'll usually place the ultrasound on their heart and on their bladder and their kidney and think about some of these other differentials. All right, so let's stop and reassess our patient. So on hospital day 2, we got a UA which was consistent with a urinary tract infection. Antibiotics were also started, and his fever resolved. His blood pressure was hypertensive, and it wasn't dropping into a hypotensive septic shock realm. And we looked at his bladder and his kidneys. There was no evidence of hydronephrosis or other obstruction. And when we look at his lungs, here are freeze images of each of his anterior lateral lung exam. If you add up his B lines here, he still has 7 to 8 total B lines, as well as a central venous pressure of 15 and 2+ leg edema. So thinking about his volume compartments, he still has moderate volume overload in his legs, moderate pulmonary edema, high central venous pressure, and his effective arterial volume was likely low during the first 24 hours of admissions due to sepsis, the urinary tract infection that we then recognized and have started treated. But now he's not hypotensive. His systemic inflammatory response has decreased, the fever and tachycardia have resolved. And his creatinine, though, continuing to rise, we think we've improved his effective arterial volume by treating the sepsis. And the other thing, thinking about cardiogenic shock, he does have moderately reduced ejection fraction, which we recognized in the emergency department. But usually with cardiogenic shock, their EF will be closer to 10-15%. Here, he should have reasonable stroke volume to handle IV diuresis and maintain his effective arterial volume. Because he had recurrent respiratory distress, we decided to prioritize his pulmonary edema volume compartment and continue IV diuresis. So on hospital day 2 through 5, we started 100 milligrams IV Lasix twice a day. And though his initial creatinine rose, again from a baseline of 1.5 to 2 to 3 during the first day, it stabilized once we controlled his sepsis and continued IV diuresis, and then actually started to improve with time. By hospital day 6, there was no longer peripheral edema. His shortness of breath had resolved, and his BNP had almost completely normalized. And we saw this creatinine improve with IV diuresis. So is he ready to go home? Well, he was having a creatinine rise of greater than 1. We addressed that and treated his sepsis. Now we have to ask ourselves, is there 7 or more B lines? That's the break point where heart failure hospitalizations will increase if patients go home with 7 or more B lines in the anterior lateral lung zones. So let's take a look at his lungs and see if we need to continue IV diuresis. So here's his anterior lateral lung zones here. And you can see diffuse A-line patterns. No B lines are detectable any further. So his total B line score is 0. We also looked at his inferior vena cava, and his central venous pressure is 3. And again, he has less than New York Heart Association class 3 heart failure. In fact, he has no shortness of breath, no orthopnea while lying flat, and there's no leg edema persists on his exam. So as we go back to our algorithm, he has less than 7 B lines, and does he have any signs of residual congestion? And he really doesn't. And these are the ones that we talk about that I like to monitor. Shortness of breath walking to the bathroom. I'll let patients get away with a little trace edema, but more than 1+ is probably too much. High central venous pressure, orthopnea, which is nice to assess when you're laying them flat during the ultrasound. I see if they can tolerate that objectively. Always listening for S3s as well. So daily lung ultrasound for CHF management has been proven to make more frequent medication adjustments and shorten length of stay by 1 day, as opposed to just ultrasounding the patient when they first come into the emergency department and maybe before going home. If you ultrasound their lungs and IVC every day, you'll recognize patients that are dry more quickly and actually can discharge them sooner more often. All right, so that's the conclusion of this talk. Let's just summarize briefly what we went over. So that common expression that I learned when I was in training was diurese until the creatinine bumps. We should really throw that out the window. In fact, creatinine rises of less than 1 is very common, and if the patient is still wet, you can keep diuresing safely. There's worse outcomes if patients are sent home when they're still wet and have signs of pulmonary edema or leg edema or high central venous pressure. Lung ultrasound is really key to the volume status exam, and it's really superior to your history exam and chest x-ray. And if you frequently reassess pulmonary edema with lung ultrasound, you can shorten length of stay. And when we think about volume status, again, it's more than just central venous pressure and inferior vena cava ultrasound. We need to think about what is their peripheral edema, what is their pulmonary edema, what is their central venous pressure, and what is their effective arterial volume, and grade these separately for a more nuanced approach. All right, well, thank you for joining me today. That was part 2 of our lung ultrasound curriculum. Again, you can see part 3 at proceduralist.org or review this one or part 1 at the website as well. Take care.